This is a case, 4-year-old boy who had a history of whitish reflex in both eyes since 2 months only. That's a little bit atypical feature about this patient. The lens is a bit swollen. Sometimes you can get that better information on the table. One of the clue to differentiate between post-lenticonus and the intumescent lens at this stage, the anterior capsule will be completely flat in post-lenticonus because lens goes behind the vitreous. There's already an opening. Here, if you can see, I'm just rotating it. It looks a little bit swollen. So chances of post-lenticonus is less. Obviously, you can see the cataract is total in both eyes. The lens is totally white here. So I'm going to inject vision blue and stain the capsule. Obviously, you need to wash all the time. You can always rotate this globe whichever direction you want with the second instrument. This is extremely important to begin the capsular axis. I make a initial nick like that. And then what I use this capsular axis forceps, you can see it has got a good grasp here and it's vertically down. That makes your capsular axis a little bit easier. If it is horizontal, you might have to bend it. So here it becomes a little bit easier for you to do it. I'm going to enter and I'm going to grab this. You can see this is the initial opening I'm going to do. You can see it is coming from the other side, but still doesn't matter. You have to grasp and re-grasp and try to complete it. You can see you have to grasp and re-grasp. Change your direction each time if you're re-grasping. Obviously, it's a bit swollen, so you have to be careful. Don't do at a time. Take your time, grasp and re-grasp, and then complete this. And with the same flow, you can remove this capsule. So you can see the part of the lens is coming out. So if it was completely intumescent, I would have aspirated a little bit of lens matter before beginning with the capsular axis. Here I did not do it because it's not completely swollen like a circle. When you do a biometry, you have a clue what is the lens thickness. Your biometry machine, most of them have something called lens thickness, LT it is written. General thickness in a child is around 3.5 to 3.8. If it is anyway crossed beyond that, for example, say 4 or 4.2, definitely you need to aspirate a little bit. Second side port incision using a myringotomy, you can make it at this stage. And when you come back, you can just give a small little bit cut so that your instrument goes very easy and smooth. The next step is using bimanual irrigation and aspiration technique. Aspirate the periphery first and then come to the center because that acts as a scaffold, and if it is a possible posterior lenticonus, you might avoid that part going down. So many times that's the technique I use. I aspirate the periphery first and then come to the center. And you should be able to turn your port wherever you want. This 360-degree movement is very important because as you can see here, as I am taking the superior part, the whole nucleus is there. It's a very soft one most of the times. It's a little bit leathery, trying to aspirate it, but it's not aspirating completely. It's definitely leathery because that's why it is not intumescent. At this point of time, probably it's best to pause. Inferiorly at 6 o'clock, you can feel the whole nucleus. And obviously, with the perception of your both the hands, this is not the typical material which will come off very easily. So I will use a little bit of phaco energy to take it out. Can I have the keratome, please? What is different here is you need to make this main port incision at the beginning. Generally, I don't do this step till I do the PPC. Again, that's two step, one, and then down. These are all things you don't expect at the beginning because there is no way I can say that this is a firm nucleus, which is not breaking with the bimanual. We don't have to chop this. So I will use a little bit of phaco energy to take it out. Okay, I need the second instrument because, it floats. This nucleus floats so much. This is unexpected. Sometimes this cortical matter can go in like that. Can you see a strand there? I'm going back to the bimanual now. There is some cortical matter left at 12 o'clock and there is some little bit firm cortical matter inferiorly. Both of them I'm going to take it out now. This is a little bit thick part here. Sometimes this can be there. So can I have the polishing? I try to remove the cells as much as possible. It's not that in toto we can take it. Just under surface of the capsule, the anterior capsule, remove as much as visible lens epithelial cells. But in a child, you try to give whatever is best possible on the table. We will try to do the posterior capsulorhexis and then implant the lens. Opening of the posterior capsule now. You can see the opening. I need to rotate sometimes to see that. The next step is to grab the posterior capsule. More viscoelastic you put, deeper you have to go. Just remember that. Can you see? It's coming on the anti-clockwise direction. So this is again grasp and regrasp. So it looks bigger, but I think in my opinion, it closes whatever small size you make it. So bigger the better. And obviously there has to be some place to insert your lens. Obviously, don't make it so big that you can't implant a lens as such. You can see this is again a slow process. Take your time, grasp and regrasp. I just do a limited anterior vitrectomy. You don't have to go very deep. Rule of thumb is around anterior 1/3. You go with the maximum vitrectomy available in your machine, which makes your life easier and faster. Initially, you can be like this, flat towards the vitreous, facing towards retina. Then you need to see this vibration of the poster capsule. That means still there are some vitreous remaining. And I come from here till here, I come like this. And then again, I change the port like that. This is for the 12 o'clock or 11 o'clock. And then if you want to see, again, I'm turning almost 360 degree and turning towards this so that this part is taken care. Your pincer grip should be good and you should be rolling this. See, this is directed towards almost 7 o'clock now. And then same way you can come till 2 o'clock and then 1 o'clock. See, I am very close to the PC. I am behind the PC now. I don't see any movement of poster capsule almost 360 degrees. This is an important step to know that you're almost full, because you don't want to overdo it, because your globe will become soft and it's not required to do too much of vitrectomy. I'm kind of inflating the bag. I'm trying to inflate everywhere so that I can go in and place this leading haptic like this. If you can see, I just want to go there, hit the anticapsule and hit it hard so that it is in the back. Suppose this is the leading haptic, go there and push it anteriorly, because if you push it anteriorly, your lens is not going to go posteriorly. Push it up so that your 2/3 of the lens goes inside. Once it goes, the trailing haptic is just completion of the nudging or rotation. Don't rotate too much unless it's required. So we are going to implant a lens. This is plus 20.5. So we have already made this incision before, and we have to go as down as possible. You can see this is going down. It's just that your forceps and the rexis is in a stable position. It won't go beyond this. You need to lift it up and then put it again inside. Somebody was suggesting that you can do vitrorexis. The problem is with the vitrorexis, you may not have stability of the poster capsule. It may not be so good. So this is one of the advantage of doing a primary poster capsule rexis, because it will be very stable. You can see this, the leading haptic here. It's in the bag there. And the trailing is above the bag. Can you see? This is a trick where here you have to put it inside. It's almost inside now. Check for yourself in all directions. It's in the bag. The poster capsule is a little bit oblong now. We need to clear it off. You can repeat your vitrectomy and then complete this surgery. You can see this part is still not gone inside. So you need to make sure that it's in the back. This is a technique where you go behind the lens. So this part you need to clear. So check exactly by going behind the lens, because sometimes this part can go beneath it. As you can see here, this is a little bit behind that. Can you see? This part is inside. This part is inside. You can see. And here it's inside. So this you have to make sure before closing. You can see this part is inside, and this part is inside, and even because ideally I would not touch this iris, because it's not a good idea to touch. Since the dilatation is not there, we need to check this dilatation part. Change your technique or whatever procedure during surgery, because it's always gives you surprise. Take adequate care post-operatively. Like in this case, I will do 4 times a day antibiotics and prednisolone 8 times per day. And then I will use a dilating drops, maybe cyclopentolate or homatropine, depending upon the availability. Maybe for 2 weeks, 1 to 2 weeks, because dilating drop is very important in addition to steroid. I will give a subconjunctival dexamethasone as well as ciprofloxacin. These are the two injections I give, because it gives some protection till the child is recovering.